Good afternoon, everybody. This is Dharmender Kumar, Assistant Training Coordinator of H&FW Parimahal and host of today's meeting. On the behalf of H&FW Parimahal, I welcome you all on this training webinar. Today we have with us Dr. Ramesh Azad, sir, Hayes Professor and HOD of Department of ENT, IGMC Shimla. Before I call sir for presentation, I would like to introduce or I would like to invite Dr. Harsaran Kaur, Principal of this institute, to welcome today's resource person and discuss some key points regarding the training meeting of today's webinar. With I also request ma'am to address the meeting. So I hand over the mic to ma'am. Thank you, ma'am. Kindly unmute yourself.
Okay, thank you. So I welcome everybody for today's webinar. And I welcome Dr. Azad also. He is a professor and head of the department in ENT department, IGMC. So as if all know that we are facing this second wave of pandemic and it is now coming down, and total number of cases are around 20,000. And the total number of deaths reported yesterday, I think, is 58. So that death rate is also decreasing. But still, we have to face a big challenge. It's very difficult for the health department to face this pandemic impact on the people's health. And we all know that we had one lecture on long COVID. So after COVID, the patient has so many problems like pneumonia, pulmonary fibrosis, neurological damage, mental illness, or mental stress, or the cardiovascular complication. Now the new problem has come up that is regarding the fungal infection. We all hear about it. And the lots of research is going on this topic. So we are telling people to cover their face with the mask, and we had one session on the mask also, how to use the mask, and I will stress upon that it should be clean mask or new mask to be used every day. If it is a cloth mask, they have to wash it properly. And the patients going on treatment with this steroids and oxygen therapy, so they also have dealt this problem. And in patients who are at home isolation under supervision of our health professionals, or the people who are sitting at home not under the supervision of any health professional, they have also come up with this problem. And so the health system is facing so many COVID-19 pandemic huge stress due to increased demand of care of people with COVID-19. Whether they are at home or they are in CCC or they are at level 1, level 2 or in ICU, even the families are under stress. So yesterday we had very important topic discussed about the management of the diseased suffering from this COVID-19 problem. So every day we are discussing one or the other topic related to COVID-19, and I think almost 24 topics are covered by now. So there is a need of the complete right information and scientifically based treatment for managing today's problem. People need to understand about the problem. So how they will understand? When we go to them, when our health personnel, they go to the community or the teams which are there, like Anganwadi people and our ASHA workers or our health educators, supervisors, when they will go to the community and they will interact with the Panchayati Raj people or the people who can help the community, and they are from the community, they can help us to sort out these problems and make the people understand about the problem right now going on. So, so that they can be given the better treatment and the mortality rate can be decreased. People, we can prevent the deaths of the people because of this pandemic, because of this COVID-19 disease. So I will not take much time. I hand over mic to Dr. Azad, and welcome you. Dr. Azad, you can start your presentation. So thank you, everybody.
Okay. So thank you very much, ma'am, for good information you have shared to all the viewers and for me also. And good afternoon, everybody, for the participants, those who have participated today in this webinar. And I shall introduce myself. I am Dr. Ramesh Azad, and HOD and professor in the Department of ENT. So, as you know, today we should discuss a very burning issue or a topic regarding COVID-19 infections and post-COVID some problems like this black fungus, which is given a name, but we'll discuss in a due course that why should we call it a black fungus or not. That is the main you see of this problem. Then, as you know, that there is the really a big surge on this in this problem of the black fungus throughout the country, and therefore our state has declared it as a pandemic in our state. So, as we know, we are all a medical fraternity, that our state of Himachal Pradesh is not having a very common fungal infections because due to the non-conducive environment for its growth. So usually you don't encounter all these issues here. But due to this COVID infection, 19 infection, because there are so many factors which leads to rise or causes this infection in so many people having a interaction with the COVID infection. So regarding COVID infection 19, I will not discuss more because everybody is well versed with the disease of COVID-19 infection. I should skip it, but we should directly go to the topic. So we'll start with the first. What is this fungus which is known as a mucormycosis? So I should give some introduction for this. So this mucormycetes are a group of fungi which persist throughout environment, which is throughout the environment seen in a soil, or if there is some decaying organic matters which lie in the fields, or may see in because most of the population they reside in the villages, so there may be some animal dungs and all these things. So these are the very good source for the mucormycetes, and usually seen these mucormycetes. These are seen usually in summer and rainy season. So if you see these fungi are not harmful to most of the people. So that's why from this this statement, if we conclude that, we should conclude that we most of the ourselves, we have some or more time has exposed to these group of fungus. That's, but we are not harboring it. We are not having a problem with these fungi. Why these fungi causes a problem nowadays? Because now these fungi causes the problem in a person, those who are having a very weak and immune system. So that is the problem causes in those type of population or the patient person. Then how it comes in the body? Now question is this, that how that is the fungus that is in the environment, but how it go inside us? So that is, it is the inhaling or breathing in of these spores through a nose, in the sinuses.
Kindly unmute yourself. You are muted right now, sir. Please unmute करिएगा, sir. Sir. अनम्यूट करिए. Yes, please.
Lungs, and which causes infection, which spread to the other parts of the body. So slide show. Slide down.
इसके बाद से ये सर
बस इसके बाद
इसके बाद
Okay, sorry. There was some technical error. So sorry for the delay. Now we are discussing that the this so this fungus, it belongs to the family Zygomycetes or Zygomycosis. There is a subphylum for this, their mucorales and entomophthorales. So this mucorales or mucormycosis, it causes the infection in human beings, whereas the entomophthorales, it is a insect infecting fungus. So in mucormycosis, it is the rhizopus which constitute 47% for its harboring or infections, whereas the mucor causes infection in 80% of the cases. So COVID-19 associated mucormycosis. This is the term coined after the infection of COVID-19, that is in a short form, that is the CAM. So this is CAM is COVID associated mucormycosis. So mucormycosis is uncommon. You see, it is I have already discussed earlier, that is uncommon, but it is once there is an infection, it is a life-threatening fungal infestation, and mostly seen in the immunocompromised, or in those patients where there is the patient met with an fatal accidents, because there is the soiling of the wounds with the debris and all infected materials. And this mucormycosis, once there is an infection or the fungal this problem, it is a very aggressive one. So due to this aggressive one, because we have seen that it causes most of the infection in a rhino, orbito, or oculocerebral system. So that's why we constitute it's a single terminology, not in the single rhinomucormycosis, not as a oculomycosis, but it is a rhino-oculocerebral mucormycosis. So it is the most aggressive form of the infection of the fungi. In India, why it is this fungus is on a surge, on a very big, you see, in a rise, because in India most of the this common risk factor for this fungus to grow is a uncontrolled diverticulitis. So it is endemic in our population. So if you see, if you see that we have read in so many articles that India is in a world is a endemic for the diverticulitis. So that's why there is a more surge of this untreated patients, not diagnosed patients. Suddenly they come to infect this COVID-19 infection, and post-COVID they are landing with a diverticulitis, this fungus infection. So if you see this rhino-oculocerebral infection occurs, this incidence rise from 40 to 58% of this mucormycosis cases. So now question is this: within the very outset, I told you that why we should call it a black fungus. Should we call it a black fungus, or it is a black? This fungus is black in color. No, fungus is not in a black, but it is due to its causing problem. That is when a due course will see that it compromises the blood supply to the part involved, where there is this fungus gets lodged. So their blood supply is impaired, hampered, and that part there is the ischemia, then there is the blackening, avascular necrosis, and that's why it becomes black. So why there is, because we are discussing regarding the COVID post-infection with the fungus. So COVID-19 infection is associated with a significantly incidence of secondary infection. So you see, because all of you, those who are participated with me, everybody was posted there in a system that they must have seen this COVID-19 infection patients having a high incidence of secondary infection like bacteria and the fungal and all these things. Why it is there? Why that is this infection is there? It is due to that is immune dysregulation, widespread use of steroids. That is not in a judicial manner that we should use it. So that is widespread use of steroids. Then there is the use of monoclonal antibodies, and then broad spectrum antibiotics for a long duration. So because we have to use it, because it is the one of the armamentarium for to treat the COVID-19 patients. Without this, and you can't treat the basic disease, basic problem, basic viral infection or COVID-19 infection. But you have to use this, but still it causes the exacerbation for the existing fungal disease. So this mucormycosis, though uncommon, causes the pathogenesis. That how this pathogenesis occur, because once this infection, the person gets inhale, so this how this pathogenesis occur. So first we start with the inhalation of the sporangiophores from environmental source. So source we have already discussed, that is the soil, infected, decaying materials, leaves, weeds, and these animal dungs, etc. And there's construction sites where the person who is working in that particular vicinity. So it is the inhalation of the sporangiophores from the environmental source. Then with the inhalation, there is these spores get deposited in the nasal terminate, paranasal sinuses, and directly it goes into the pulmonary alveoli down to the lungs due to the, so both in inspiration phase and expiration phase. Once there is this deposition of the spores, sporangiophores, then there is a host pathogen activity starts. So this host pathogen activity start in the form of as a defense system. So there are a defense system that usually once there is a encounter by some foreign body on the our system, so our defense start working. So first line of defense in our body, as usual, and everybody knows, is the macrophages. So once there is this deposition of these spores, this first line defense start working, that is the macrophage against these spores. So spores, but this spores, because once it goes inside the body, there is the growth start, germination start in the form of mycelia and hyphae. So if it doesn't stop there with the macrophages fail over there, then the second line system comes in a working. So that is the second line defense system is formed by the neutrophils. So that work against the hyphae. So macrophages and neutrophils are required in a sufficient quantities to destroy the spores and the hyphae. So with this, you should know that either it is a deficient macrophages or neutrophils, so there it will not destroy the spores and the hyphae, so there is definitely germination. But if the neutrophils and macrophages are in a sufficient quantity, it will definitely make it dead over there, and that's why there is no disease harboring in themselves. So with this two defense system, those who are having a good immune system, that's why there is no disease. But the once the immune system is down, not working properly, so there is the harboring of the disease. So qualitative and quantitative abnormalities of the neutrophils, monocytes, and macrophages increase the risk of developing mucormycosis. So due to diabetes, we have discussed that it is mostly seen in the diabetes. So in diabetes, what happened? The macrophages and monocytes fail to suppress the germination of spores. So and there is if there is a diabetic ketoacidosis, and this ketoacidosis is associated with the impairment in the neutrophil functions. So all these causes then altered iron mechanism with increased ability of the unbound iron, serum iron. So once there is an unbound serum iron in the body in a sufficient quantity, these are utilized by the mucor organism to grow. So with this, the or this fungus start growing in a large scale. So then is the pathophysiology. Once it is there, that how our pathology and physiology is involved in this. So it is, once these system is this growth of fungi is there, so it start invading the vessels, the small or medium sized vessels, angio invasion with the formation of the thrombosis, and then finally the tissue necrosis. This is the key features of a mucor. So angio invasion occur actively with the interaction of the endothelial lining of the blood vessels. Now next, with this pathophysiology or pathogenic activity, if we see in a nutshell, why mucor kills? Otherwise, I should go to this slide in the end, but in a continuation, I should discuss it over here, because this angio-invasive property of this mucor, it is widely disseminated. There is a thrombus formation, ischemic necrosis, that is the due to thrombus, and there is the blocking of the flow of the circulation. Then there is a ischemia, part gets dead, secondary bacterial infection occur, and finally septic shock. So other causes of the mucormycosis. So that is, we have related to the first COVID-19 infection, post-COVID-19 infection. But there are some other causes also for the mucormycosis, that is related to the some malignancies, like hematological malignancies, hemopoietic stem cells transplant, some solid organ transplantation, and we have discussed some steroids judicial use prolonged for a prolonged time, and then in prolonged voriconazole prophylaxis, because no doubt it is an antifungal voriconazole, but it is used for a prolonged period, causes mycological vacuum. So in this vacuum, so there is the mucor gets more emerges for the compensation. So these patients of COVID-19 infection required having a high risk group. They require early and regular post COVID infection treatment by the ENT surgeon. There you should have a periodical examination of these patients by ENT surgeon or ENT people for to see the mucormycosis infection in the nose and paranasal sinuses. So with this slide, if you see, we make COVID plus steroids plus diabetes means equivalent to the mucor, means there is every chance of this mucor harboring. Then when and how to suspect the COVID associated mucormycosis. So for as a ENT, I'll discuss that there's some clinical clues like nasal block, congestion, nasal discharge, maybe bloody or brown, maybe black color, or there is a local facial pain, numbness in the face, or patient may have a fever, headache, retroorbital pain, or toothache, loosening of maxillary teeth, and jaw involvement. So that is the really clinical features or symptom and signs which you can see in patients, those who you want to examine for the suspicion of the mucormycosis patient post COVID. So there may be some eye signs, that redness, swelling of the eye, blurred double vision, with the pain, paresthesia of the skin lesion, and the involved should come red or vicious black. So pathognomonic features of this disease is a ischar, necrotic ischar, that is seen in the nasal cavity and the terminates hard palate or perinasal or periorbital skins are the signs of rapidly progressive infections. What is the sites where you should locate the sites for the mucormycosis to see the mucormycosis? So the nose, sinus, and orbit is the major site for the location of the mucormycosis. But there it can be intracranial also, pulmonary, or maybe in cutaneous, gastrointestinal, and disseminated. That is the vascular in origin. So sinus infection is the most common presentation. And whereas in patients with diabetes, the most commonly presentation may be this, but pulmonary can not be ruled out. But these patients, if have some problems, so that which common site you have for the this harboring of this fungal infection. So in case of diabetes, no doubt rhinocerebellar or sino-orbital is there, but there may be a cutaneous. But in case of malignancy at transplants, it is the pulmonary and disseminated fungal infection of mucormycosis. In case of drug users, those who are taking a drugs, IV drug, that's it's mostly causes the endocarditis. Whereas in case of malnutrition, if there is because there is also a lower immunity, so GI mucor is mostly seen. But in case of desproximacin, that is pulmonary or disseminated type of mucormycosis. And where in case of trauma, it is, you see the cutaneous one. So what is the incidence of this mucormycosis and presentation wise? So if you see the presentation wise, mucormycosis incidence is most commonly it is rhino-orbital. So that's why the name that we spell it in a single term, that rhino-orbito or rhino-orbito-cerebral. So more than 40%, 41% is rhino-orbital, and after that it is rhino-orbito-cerebral. It constitutes 27%. Whereas the sinus involvement of this mucormycosis is alone is only very less, that is 8%. But whereas the pneumonia comes in a less than 10% or 7%, or other cutaneous gastros constitute the incidence of 10%. So clinical features, though I have discussed, but there I have make it in a bold manner, that is those we can discuss it again. That is the onset of this disease start with the nasal stuffiness, dark blood tinged and nasal discharge, facial pain we have discussed already, but fever and lethargy, no doubt that is there, or there may be a facial anesthesia. But what is the hallmark features for our colleagues, those who are there in other institutions? They should make it sure that once you will examine the patients of for this infection, you should see the black necrotic scar on the nasal terminates and the palate. That is the hallmark features, characteristics features. We have 3, 4, 5 patients over here also we have seen, and in all the patients there is the blackening or the blackening of the nasal terminates, as well as 1 or 2 patients there is the palate ischar, necrosis of the palate. So that is the hallmark features of this. Then there is the periorbital or perinasal swelling and edema, no doubt. and proptosis, chemosis, ophthalmoplegia, and ptosis of the eyelid. That is also almost in those patients, there is the involvement of the orbit in all patients. These are the clinical features of the patient comes to us. Then loss of extraocular movements are there, no doubt. Decreased visual acuity and blood visions, and patient may have blindness. So clinical progression. So how this disease progress clinically? So we have make it in stages. So if this infection of nasal mucosa and sinuses is there, we stage it at 1. But if there is a involvement of the orbit, that is the orbital apex syndrome, which we had discussed these symptoms in the previous slide, that is superior orbital fissure syndrome, etc. So we stage it in a stage 2. But there is a stage 3 also, once there is the cerebral involvement. And with the intracranial spread occurs in the following routes, that is through ophthalmic artery, superior orbital fissure, and in the cavernous sinus thrombosis. Once we have come to this level, then question comes that how to diagnose it. You have examined, features are there, everything is with you, but how to diagnose it? Now it is the very big, you see, question mark. We have put a question mark that how to examine. No doubt, first, mucormycosis is a medical emergency because the patient is having a high rise of sugar, maybe in a ketoacidosis, maybe having a other problem with the patients. So first is the medical emergency. Medical personnel should examine the patient. Then the suspected patients should undergo a appropriate radio imaging study. That is, in the radio imaging study, we do a CT scan for the paranasal sinuses, and then the MRI with the contrast. And with that, after that, we have to do the clinical examination or endoscopic examination. That is, we call it as a diagnostic nasal endoscopy, DNE in other term. So diagnostic endoscopy just for the collection of material of a tissue or procure a biopsy so that you can do the diagnosis with the help of a microscopy of a culture or a histopathologically. So that is the 3 points where we make a diagnosis. So as I told you that mucormycosis is a medical emergency due to diabetes, ketoacidosis, oxygen inhalation, irrational use of steroids and other associated diseases. So first they should examine the patient. Then is the complete ENT examination, that with the endoscopic examination, we should see the cheek, first ENT examination, the local examination, the maxilla, cheek, swelling and tenderness, then oral cavity for the palate ulceration. If there is a loosening of teeth, loose teeth, that you have to see. Then examination of eye proptosis or vision movement and corneal reflex. Then crusting of nose or face, skin, and then the paresthesia around the nose or loss of sensation of the face. Then is the diagnostic nasal endoscopic examination. So in diagnostic nasal endoscopic examination, there is a discoloration of the nasal mucosa, turbinates, that we have in this picture. You can see there is a this is bluish discoloration of the turbinates is there, and secretions can be seen, that is a blood stain or some thick secretions with blackish discoloration. And then the sphenoid sinus, or the most common sinus involvement is the ethmoid sinus. That is the radiological investigation. In the radiological investigation, as we have already, I was already discussing, was the CT scan. So CT scan of paranasal sinuses otherwise has no role to diagnose the mucor, but it has only, it shows some bony landmarks, whether it is intact or there is any erosion, or it is the roadmap for the further surgical intervention once we have to do some surgical intervention. So it is there. But the gold standard radiological investigation for this mucor is the gadolinium enhanced MRI for the paranasal sinuses, along with T2 images and PET suppressed scans that can diagnose the mucor. So that is the radiological investigation, because with this investigation you can clinch that how much of tissue is to be derived, and how it is helped, we'll discuss it. That is the enhancing area. Once there is an enhancing area, that we have not to be derived. It is the dead portion, that is the loss of the contrast enhancement. We'll discuss. No. So in city, you see there is the erosion of the bones. If it is there, that is the lamina papacea, or maybe going into the skull base. If there is a disease is very advanced, or a roadmap for the during surgery for a surgeon. So with this, if you see this CT scan, we have put an arrow. There is a erosion of the lamina papacea. So we are discussing the enhancement and the loss of enhancement. That is, if there is a fungal hype in a tissue, it causes the inflammation. So there is the enhancement, because the gadolinium contrast. So there is the enhancement which causes the fungal inflammation. But if there is a micro invasion, once there is a micro invasion, there is a loss of due to thrombus. There is a loss of vascularity supply. So once you give a contrast, so that contrast don't reach to the particular site. So that is causes the loss of contrast enhancement in that particular area. So that is due to the micro invasion. So loss of contrast enhancement make it black, and that portion you have to okay. So if you see, there is the thickening or intraocular muscles of the orbit. This MRI, if you see, it plays a very major role in assessing the extent and involvement of the complications. So post contrast enhancement is as may rule the findings in a angio invasion. So that is the loss of contrast enhancement. Whereas in MRI, the findings you can see there is the black terminate, thickening of the medial rectus, orbital invasion, or there may be a optic nerve edema. So MRI is a investigation of choice. Then is the microscopy. How to improve the diagnosis? That is lab diagnosis. So it is due to the specimen quality. To avoid this specimen quality, how it will help avoid sending swab, because it will give a false negative results. So at least scrap or tissue. Then is this fluorescence and the experience of the microbiologist or the so now role of KH mount. KH is a strong base which softens the or digests the tissue and clears cellular and keratin debris. So it leaves the fungal hyphae or cell wall intact. So it clears the background and allows the visualization of the fungal elements under a microscope. So the mucor there, the mucor looks like a broad aseptate ribbon-like hyphae branch at 90 degree, and occasionally may seen these hyphae are seen. Whereas the rhizopus is a septate, thin branch at the 45 degree. There is one study, there is a comparison of the conventional rapid methods in diagnosis of superficial cutaneous mycosis that is based on KH. So KH is definitely give a very good specificity and positive predictive value in 98%. If it is this stain is occur within 30 minutes, because it digests more than 30 minutes and it improves the diagnosis by the good digestion, fluorescence, and experience. Then is how to collect this sample and transportation. So sample collection and transportation. We are doing a diagnostic endoscopy. We are collecting the sample. So sample, once we have collected the sample, that is maybe a crusting or a tissue or a part of the, scraping, you have to collect in a sterile container in a sterile saline. So this sterile saline and container, if you are collecting in a KH, that is to see the presence of fungi. And if it is the fungal culture, you are sending it the fungal culture, it is to see the type of fungi. But if you are collecting it in a 10% of the formalin, it is for the histopathological examination. So histopathological examination for to see the fungus or any bony lesions or any malignancies, whether it is a malignancy or they are to differentiate it with the other disease along with that. So specimen should be collected aseptically in a sterile container, and it should be transported to the laboratory within 2 hours. Should not be any delay. So avoid sending swabs that I have discussed earlier, that because it give a false negative reports. So culture. So culture, we have to should be in this transport should be as soon as possible, and there should not be refrigeration of the tissue, because refrigeration kills the mucorales within 30 minutes. So if you see this slide, this slide show the branching pattern that is at a 90 degree. So it is the mucorale, and this is the arrow show that is exactly at 90. And this branching pattern here, it is a septate hyphae and 45 degree. So it is rhizopus. Now, other investigations. We have discussed the investigations, radiological investigations, and this investigation for KOH staining, culture, and histopathological. But other investigations. So other investigation to see the pathology. That is, first, I will not discuss this COVID for the COVID because these patients are post-COVID. So I know. But if you have any still some element in your mind that a patient might have a fever and all these things, they have no previous history of COVID and all this, then you have to do RT-PCR, rapid antigen test, and some IgG or IgM or CBNet or HRCT chest. But the routine investigation like blood sugar, HbA1c, IL, interleukin 6 markers, serum ferritin, and CRP, and some serum creatinine. All these investigations should be done in a routine to see the pathology. Why? Because you have to see whether there is a sufficient neutrophils are there, whether there is neutropenia is there, lymphopenia, or whether IL markers are raised, or there is a serum ferritin is increased, and whether increased CRP and serum creatinine also, these platelet counts, etc. That's two rule of the pathological involvement of the patient. So now it is the principle of the treatment. What are the treatment principle? So as we see, the risk factors are there, some immunosuppressions are there. So these we have to get addressed. So risk stratification, reversal of the immunosuppression is a part of the treatment. But no doubt, there is a medical management is one of the treatment, but the surgical debridement have a main treatment for the mucormycosis. So it is a guideline established where there is that with this guidelines, we have to follow this as such. That is, early diagnosis and prompt treatment is essential. Once there is a suspicion, there is a patient COVID, post-COVID, all factors are there in the body. Patient have a complete diagnosis, this investigations, and you are making it that is the making it as a strong suspicions of the mucormycosis. So early diagnosis and prompt treatment should start with the liposomal amphotericin B. So early diagnosis and prompt treatment is essential, especially in rapidly progressing lesions. And if delay is there in this at this stage, so for 2 or 6 days, so mortality of the patient is by 15%. So role of surgery in mucormycosis is, because that is a dead tissue, necrotic tissue, dead tissue, and there is no blood supply to the particular area. So there is the disease progressing in the from the nose to the orbit, from the orbit to the other parts, that is maybe in the intracranial or the cerebrum. So you have to remove the devitalized tissue. So debulking of infected tissue, allowing the faster action of the antifungal agents with a smaller burden of fungi to establish the histopathology with this removal.
सर म्यूट हो गए, अनम्यूट करिएगा प्लीज, म्यूट हो।
Next. So, role of surgery in the mucor is removal of revitalized tissue, debulking of infected tissue, and we can get the histopathological diagnosis once the tissue is taken out, and for the microbiological diagnosis. So the aim of this surgery is there is a faster action of antifungal drugs, which should act in a remaining tissue which is having a good vascularity or good supply, so that it should not get affected. Or then why should remove necrotic tissue or devitalized tissue? Because due to angio invasion, there is a small or medium-sized vessels, inflammation and occlusion. So rapid necrosis and tissue damage occur. So there is a systemic medication does not reach to the actual focus of infection. So that's why we want to remove it. So thus removing all necrotic or deviated tissue from the sinus and orbit. So isolated sinusitis is curable with timely surgical intervention and systemic antifungal agents. And there should be a low platelets count must be corrected with transfusion before surgical intervention. So, sorry, the surgical debridement is fundamental for successful management of mucormycosis. With the angio invasion and extensive necrosis, antifungal therapy alone is inadequate for control of infection. Surgery should be considered early in the course of treatment with the goal of removing all necrotic tissue. So, survival is enhanced with the combined medical and surgical approach. Now, that is with this. But what next we should do? If there is a involvement of the orbit or other part, that is the cerebral part, what we should do? Whether we should give a transcutaneous retro or bulbar amphotericin B, should we have an orbital debridement or a orbital exentration? So if there is a diffuse extracorneal involvement with the enhancement not fit for a surgery, these patients should be taken for a transcutaneous retroorbital amphotericin B. And if there is an involvement of fat and muscles, the medial compartment of the orbit with the loss of contrast enhancement, then you should do the debridement till the fat starts bleeding. But exentration should be carried out in those patients when there is extensive involvement of the intracorneal tissues and there is the orbital abscesses and there is the globe tenting and so orbital excitation should be done in those cases when there is the radical removal of the orbital contents and removal of the dead necrotic tissue, reduce the infective load of the patient. So, which portion is salvageable or what is non-salvageable? If there is a fungal hyphae in a tissue which causes inflammation and enhancement, that patient could taken for the salvageable treatment. When there is a microangio invasion, loss of contrast enhancement, it is non-salvageable. So if there is any intracranial extension, in an intracranial extension, the involvement of the leptomeningeal, early cavernous sinus involvement, patient is young, you should go for the orbital exentration. But in case of carotid artery involvement, pseudoaneurysm or cerebral infarct, the patient should have a palliation. So there is some proposed staging for the rhino-oculocerebral mucormycosis. We stage in a stage 1, stage 2, stage 4. In stage 1, there is the involvement of the nasal mucosa. Stage 2, involvement of the paranasal sinuses. Stage 3 is the involvement of the CNS. So that we have stages it. And what is the outcome? What should be the outcome? So outcome is if we do radical surgery of the patients in such type of patients, the local control of infection was obtained in 90% of the patient after a radical surgery involvement. But in patient of limited surgery, only outcome is only 40%. So that is the outcome. So debridement. So once we are doing debridement, so sometimes debridements go in such a way that you keep on debriding it, and later on you have to prepare this patient with the other kind of surgery, plastic surgery and all these things. But the mortality of the treatment from 32% according to the organ involvement is there. Then is the prevention and control of this infection. That is we maintain the adequate host defense, control diabetes mellitus, shorten duration of the neutropenia, and use of steroids should be judicially, maintaining appropriate environmental control and good healthcare facility to avoid aerosol of the soil and dust and debris. The construction activity in the hospital should be restricted. Air conditioning and ventilation system monitoring for the microbiological contamination and preventive posaconazole and is possible theoretical for clinical trial. Now, treatment with the amphotericin B. It is the drug of choice as a first line. So this drug, that is the formulation is in the form of lipid formulation. Amphotericin B include colloid dispersion, amphotericin B lipid complex, and liposomal amphotericin B. The liposomal amphotericin B is the first line of treatment in adults. Amphotericin B lipid complex could be used in cases with any CNS involvement. But in neonates and pediatrics patients, the liposomal amphotericin B and amphotericin B lipid complex is strongly recommended as the first line of the treatment. The dosage is very important. The conventional amphotericin B the dose is 0.5 to 1.5 milligram per kg body per day, whereas the amphotericin B liposomal complex, the doses are 5 milligram per kg per day. But the liposomal amphotericin B, the doses should be calculated as 5 milligram per kg per body per day for nose and sinuses. And if there is a CNS involvement, it should be 10 milligram per kg per day. So full dose must be given from the first day of treatment and must not be gradually increased until we'll see the patient benefit of the patient. Then is the how this amphotericin B work. The amphotericin B binds with the ergosterol, is a component of a fungal cell membranes. It forming the pores that causes the rapid leakage of the monovalent ions and subsequently the fungal cell death. This amphotericin B primarily affect as a antifungal agent. So it acts as an antifungal agent, whereas isavuconazole and its triazole antifungal with a broad spectrum of activity has a good safety profile. It acts by inhibiting the fungal cell membrane synthesis. So this is the its action. So that's why salvage therapy is always done with the posaconazole and the isavuconazole. The route of administration or method of delivery of and duration of the amphotericin B, it should be that if before starting the amphotericin B, you have to hydrate the patient with 200 ml dextrosaline or and saline, and after administration of the amphotericin B, again 200 ml of dextrosaline is given, and equal amount of the dose calculated is mixture with the same amount of the distilled water and dextrose, and it is given in a almost 1 and 2 hours per IV. The treatment should be started as soon as possible. There should not be delay. Amphotericin B therapy is linked to increase the mortality. So delayed amphotericin B based therapy beyond 5 days of onset causes the double mortality. If the patient is waiting for surgery, the perioperative amphotericin B should be started immediately. To monitor the amphotericin B complications or side effects, we should have serum electrolytes, LFT, renal functions, hypotension, and to see for the tachypnea. There are other routes for administration of the amphotericin B. These are nebulized form, also seen effective in some cases, but not in all. Some intralesional and intrathecal routes are also like, and there is a other antifungal drugs which is in use, that is the posaconazole. It is used for as a salvage therapy, but not as a primary therapy for the treatment. The preventive posaconazole in high risk patients is some question mark whether it should give or not, but steady concentration of posaconazole in plasma is reached until 7 days of therapy. Its preparation comes in the tablets forms, in the oral suspension, or in as an injectable. But the dosage is in oral dose. It is 300 milligram BID first day, and then followed by 300 milligram per day for a 3 to 6 months or a minimum of 6 weeks. Then it depends on the clinical or radiological regression, whether we have to diseases regressed, so then you can decrease it. But oral absorption is a suboptimal if the patient have some other problems like mucositis, diarrhea, and other acid suppression therapy or a poor oral intake. Isavuconazole, the other antifungal agent, it is approved by USA and in or European Union in 2015 for the treatment of mucormycosis. It is available in injection and oral formulation, both used for a soluble. If amphotericin cannot be used as a step down. So for the step down therapy, this isavuconazole is a best drug. So dose is almost loading dose 200 milligram 3 times a day for 1 or 2 days, then followed by 200 milligram day for 3 to 6 months or minimum of 6 weeks, following the clinical radiological regression of the disease. And then maintenance dose, if you have to give, it is 372 milligram IV or orally once a daily. The advantages of isavuconazole over posaconazole is it is non-nephrotoxic, no dose adjustment in liver failure, so not hepatotoxic, no dose adjustment in obesity also, and it's a good viability. It is also good effective against CNS infection, and there is a few drug interaction with this. So then there is other form of treatment is reversal of underlying host impairment. So when there is a hyperglycemia, metabolic acidosis to be aggressively corrected. And if steroids are there, so temporary discontinuation of steroids should be done. And if the use of deferoxamine therapy is there in CKD, it should be discontinued. And in severe neutropenia cases, granulocyte transfusion may be given. So in nutshell, what I should summarize, the mucormycosis should be managed in a mucormycosis ward with the multidisciplinary approach. It is not a single department approach, so multidisciplinary approach, start from the medicine, radiological, ENT, microbiology, and other specialties like maxillofacial and plastic surgeon, neurosurgery, ophthalmic approach, ophthalmologist. So that is the multidisciplinary approach. It is not a single disciplinary approach. So because this this problem needs aggressive sinus debridement, has a good systemic amphotericin B, reversal of diabetes status or immune suppression should be there, and you need a sequential imaging, and that is a key role, putting a key role there, because until unless you see the normal structure after debriding, and that's why you need a good imaging system. So contrast MRI and CT scan as to see the bony window, bony involvement. Then there is a treatment plan should be have a regular follow-up of the patients. And it is there that all blind eye should not be taken out. Why there is a spike in mucormycosis? Now I'll go see briefly there. There is a spike in mucormycosis. That is, in general, any disease happens when there are some factor intersects, pathogen versus or a virus, fungus, etc. Host, environment, human host factors. When pathogen is strong or host are weak, or environment is conductive disease results. In case of mucorfungus, evades impaired immunity, makes use of some ambient conditions to invade the epithelium or endothelium, then they make this happens include. There is an increased fungal virulence, zinc, iron overload, acidosis, ketone bodies, low oxygen, impaired host defense, steroids, diabetes, use of monoclonal antibodies, tocilizumab therapy, post-COVID impaired immunity, poor oral hygiene, conductive environment. Then, as we were discussing about the reusing of the moist mask, living near construction area, poor hygiene in oxygen supply. But none of these are rare, but they don't have together often. But without COVID, some of the risk factors are more important than the others. So mucor is basically an opportunistic pathogenic. So our job is to not to deny it as many opportunities are still possible. So with this, I thank you all for my deliberation. And if there is any query, any question, you are welcome to, we can discuss.
Thank you very much, sir. It was very nice presentation and informative one also for all of us. There are a lot of questions from participant.
Yes.
मैं एक-एक करके सर पढ़ता हूँ.
हाँ जी.
और उसका आप जवाब देते रहिएगा. उससे पहले अगर कोई ऑडियो वीडियो के जरिए प्रश्न पूछना चाहता है, मोस्ट वेलकम, पूछ सकते हैं. ओह सॉरी, मैं अनम्यूट करना होगा. प्लीज काइंडली अनम्यूट योरसेल्फ. अब आप कर सकते हैं, आप सभी कर सकते हैं. यस सर.
Sir, I have a question to ask. We see so many patients of mucormycosis in dermatology, and my personal opinion is कि maxillary sinus में reside करता है as a common cell. क्योंकि सबसे पहले डेंटिस्ट्री में भी ये आ जाता है, mucormycosis के बड़े sinuses हम देखते हैं, वहां से start होता है. Then it comes on the skin, we see it outside, just near the maxillary sinus externally. Does it reside in the maxillary sinus? Are we looking in the wrong place for mucormycosis?
No, this maxillary sinus we see, we have in the very outset I told you that because there is an entry in the sinus, this is the nose, then it is the this spores or this infection, there is the terminates and then it go into the paranasal sinuses. That is the maxillary sinus. No doubt it is there. That's why there is because once there is the maxillary sinus, that's why there is the loosening of the teeth. I have told you that is the loosening of the teeth is there. No doubt.
Thank you, Azad sir.
Okay, thank you.
There is one question, sir. ये है गुलाम मोहम्मद जी की तरफ से. अगर खुद पूछना चाहते हैं तो पूछ सकते हैं, नहीं तो मैं पढ़ देता हूँ. What is the role of zinc once diagnosed? Can we give antifungal? Is there a role of industrial oxygen in development of the mucormycosis when to do the surgery?
Actually, it is debatable, है ना? Still, there is no literature whether this industrial oxygen causes this problem, but it is definitely there because if there is oxygen, it is purely 99%. It is a pure oxygen, but it is the delivery of the oxygen, that how you deliver oxygen to the site. If the container or the line or the pipe or the moisturizer agent or the water which you are using there, and it causes the infection of the this spores and all these things. But otherwise, there is no literature with us And on this point, I can't comment that this oxygen should be given there, because we have a medical oxygen definitely have a purity of 99.5%, because it comes, we prepare it through a serial of repeated compression and filtration and purification of the cylinders, and all things are there. So I don't think whether this have made a sense for this.
There is another question from Dr. Ramesh Bharti sir. अगर आप पूछना चाहते हैं सर, मैं रिक्वेस्ट करूंगा आपकी अनम्यूट करें अपने आप को. आप डायरेक्टली सर से पूछ सकते हैं.
Good afternoon, sir.
Good afternoon, Dr. Bharti.
It was a nice presentation, sir. I have a little confusion. You said higher iron load is a risk factor, but then you said iron chelation is also a risk factor. So what is actually the process?
Chelation, that because it acts as a citrophore, no? Because this iron is unbound iron. Unbound iron is there because it is a free iron. With these fungus, it harbor these iron for its germination and its growth. So that's why, because this iron, chelating iron is there once in the CKD, so it should not be given in a larger quantity. So it should be avoided there.
So you mean iron chelators also, you know, they,
yes. Citrophore, they act as a citrophore.
And zinc also.
Zinc is the same thing. Zinc is there because it make a conducive environment for the growth of the this mold.
There is one question at YouTube, sir. It is from Dr. Rajneesh Sharma. Sir, can it be incidental finding on CT? Sir, can there be only presentation of headache without other symptom? Sir, we should start amphotericin B early before surgery.
No. What is there? Because to start amphotericin B, because it is no doubt it is for the benefit of the patient. But thing is that when we have to start the amphotericin B, I have told you there is a guideline, or we have seen, because amphotericin B is a drug which is a very toxic also. It is not a very, safe drug to use. So that's why I am telling you that once you are having a very, very good suspicion of the strong suspicion that patient is having a mucormycosis. Because how? Because you have to examine. We have so many points in favor of diagnosing the mucormycosis. We have the list of examination. We start from the face, facial pain, redness, nose, examination of scar, eyeball, vision, all these. Lot of points are there. So at least 1, 2, 3 points should be there, along with the headache. It is not the isolated headache. There is also other point for this problem for the headache. So it is not that single headache will make a point in favor of this fungal infection. No, it is not there. So you should not start the amphotericin B at this point. Not at all.
Thank you very much, sir. There is no more question.
I want to ask one question.
Yes, please welcome, sir.
I am Dr. Pradeep from Mandi.
Okay, Dr.
So we know that these tetracycline groups of drugs, they are the #1 drugs in causing opportunistic infection. And why we are using the doxycycline so widely in our these anti-COVID kits? People are giving even in asymptomatic cases also. This is not the main cause of mucormycosis like infections?
Definitely what I mean, because
on the top of it, some person are taking double antibiotic, azithromycin also, sometimes amoxiclav also.
Yes.
Not only this, but the chemists are giving even to a patient who are negative. They are using it as a candy. Doxycycline has been used as a sweet candy.
Definitely. It is there, no doubt, because जब पहले pre-disposing factors आए थे उसमें I told you that is the broad spectrum antibiotics. We are using it. Broad spectrum means so many antibiotics we are using it here. So it is no doubt tetracycline is there, doxycycline is there. But now we are moving ahead with the passage of time. We'll see that once we'll see more large number of patients of such type of patient, we'll make a statistics of all these patients, gather statistics, then we'll come to the clinical conclusion. Like that, first we had a COVID-19, 1 or 2 patients, they are all over the world. So we had not have any idea which drugs we should use. But it is by default, we are making, is it not a doxycycline is still, in some country it is not used as a doxycycline. We are using, sometimes azithromycin are used some in some countries, we are not used. But that is there, no doubt. But we'll make a study, then we will come a conclusion, and all is we should. But the drugs which
Sir, by that time many people
definitely
have gone.
Definitely that is there, no
Sir,
doubt.
what was the basis of using such? I think ये तो बिल्कुल नहीं यूज की जानी चाहिए थी. किस आधार पर स्टार्ट की गई थी? कहां से किसने स्टार्ट की होगी?
देखो इसके में it is really difficult to answer me.
Very irrational. Sometimes.
No, really, it is. You see that there in Punjab they are delivering a corona kit. Corona kit, from the first they are using steroid. Dr. Anurag will.
नहीं sir, ऐसा ही है, हर जगह ऐसा है.
He'll agree. He's laughing there, and Anurag that so that is there, no doubt. Okay.
Sir,
I have a question.
Sir, cost of amphotericin B, cost of posaconazole, hexaconazole.
हाँ, ये थोड़ा सा I should ask. Definitely, we should have a knowledge of all these things, na? And it is no doubt it is very costly, and it is very costly.
I think somewhere around 50,000 to 1 lakh rupees.
Full course.
Full course.
Full course, yes, definitely. Almost. It is touching 1 lakh. Yes, definitely. Full course.
Redmi Note 8 Pro. आप पूछ सकते हैं अपना प्रश्न. हैंड रेज किया आपने. जी.
Sir, I just want to ask that same conditions were there last year also. There was COVID and all, but suddenly it has. This year we see there are more cases. What can be the reason for that?
More cases of
this black fungus infection. Last year also people were suffering from COVID and similar conditions. Maybe it is the new mutants or the new variants that are putting.
Yes, sir. Yes, definitely. आपने आंसर ही कर दिया खुद ही. Because you have answered. Because we have a lot of debates, a lot of our seniors, those who are deliberating on a national channel also, and for last 2-3 days it is there, because our director from the AIMS and other ICMR fellow, they are debating on this, because it is the newer strain that is causing this is more. But no doubt it is the not judicial use of drugs properly, just like steroids and all these things, and use of these monoclonal antibodies, it is called to suppress the immunity so high in the patients. Immediately you jump all these things ki bhi हमारे IL interleukin इतने ज़्यादा बढ़ गया है, and CRP is raised, and we should start with the trastuzumab, because these are the drugs. No doubt for a shorter gain is there, but in a longer duration these causes these side effects are there.
So there may be another reason also.
Yes.
Last year, sir, these kits were not available widely.
Yes, these were not available widely. Yes, no doubt.
So once again, sir, thank you very much. अगर कोई और पूछना चाहता है तो please most welcome. Otherwise, I would like to invite once again Dr. Harsaran Kaur ma'am, principal of this State Institute Health and Family Welfare, to conclude the session with vote of thanks to today's resource person, Dr. Azad sir, and all the participants. Once again, ma'am, kindly unmute yourself. I hand over mic to you.
Okay. So I have listened all the discussions regarding this mucormycosis. Still the study is going on, still the research is going on. So still they are trying to find out some other way out for this infection. First of I'll say that prevention is better than cure. पहले तो self medication बंद करवाइए. जो लोग जो self medication ले रहे हैं without consulting any doctor, any health worker or any paramedical staff, they are on self medication and sitting at home, and then later on they come with the problems. And the other thing, the local people, whosoever, I don't want to take name of anybody, giving heavy dose of steroids, this is one of the cause. And somebody was saying that industrial oxygen, so the industrial oxygen is not given as such, but it is been purified to medical oxygen, 99% are said. So the medical oxygen is given, it is not the cause for this right now for this infection. And this infection, still the research is going on, even the higher authorities, agencies, they're working upon that, and our Indian doctors are also in that. So there are so many, I mean, the substitutes for this drug, but the availability of these drugs is not that easy, and somebody said it's very expensive also, and everybody cannot afford it. The middle class people, low class people, they cannot afford this drug. So I would say I conclude this session. So everybody has given their views, and they have right now. I think the people have so many questions about it. So I think so. We will end our webinar today.
Coronal से तो नहीं हो रहा ये mucormycosis?
I have no idea about this coronal, and people should not go for all these things. I think so. We should be. मैंने पहले शुरू में ही कहा था. We have to base on the scientific things, and the information has to be right. And the media is giving wrong information, then don't go for that. और आप सब educated लोग हैं. आपकी teams में, MOs की teams में जो आपकी task force बनी हुई है, उसमें ठीक जो है वो information आगे दीजिए. इसीलिए हमने MOs को यहाँ पे इसी webinar में ज़्यादातर रखा है. और बाकी तो ये है कि इंडिया में तो I don't want to say now anything. So we have to take care for each and every person's life. That is very important. We don't want to make anybody die because of the neglected things. कि कोई neglect हो गया, कोई घर पे बैठा रहा और कोई treatment पे तक नहीं पहुंच पाया. So we don't want that. Okay, Dr. Azad, thank you very much to be with us, and you have spared this valuable time. Thank you very much, and thank you everybody.
Thank you very much. Thank you.